This lecture will talk about care of patients with peripheral vascular disease of the venous system. Peripheral vascular disease can either be venous or arterial in origin. They have very different symptoms and very different treatment, and it's important to differentiate between the two. For instance, on the left here, there's an arterial ulcer, and on the right, there's a venous ulcer. They look very different. They are caused by very different things, and they are treated very differently. This picture is from your book. I don't think you need to memorize any of this. Just wanted to point out that it's there and it gives you an outline of all the different arteries and the veins. If you recall from your anatomy class, the arteries, veins, lymph, and nerves all run in a bundle. And so for every artery, you'll have a vein and vice versa. Thrombophlebitis is the most common venous disorder. The leg veins are most affected. Any vein can be involved, superficial or deep vein, and deep vein thrombosis is the most serious form. So platelets, back in the A&P lecture, I talked about the endothelium that lines the veins and how it's supposed to be very slick to make sure that the blood cells can pass through and don't attach themselves to it. Well, for some reason, a platelet may attach itself to a wall and a tail forms on that platelet, and that attracts more blood and fibrin. And as that tail grows, it kind of drifts along in the blood flow and causes turbulence and clot formation. So you've got this clot followed by inflammation in the vein because the clot has attached itself to the vein. You have platelets, red blood cells, white blood cells, fibrin, all that. And so this tail is kind of drifting along, and then all of a sudden turbulence can cause it to embolize and break off. And that's when a thrombus becomes an embolus. Virchow's triangle is the three things that predispose people to thrombophlebitis: stasis of blood, damage to the venous endothelium, and hypercoagulability. So here is the triangle, the three different things that can predispose you to um, thrombophlebitis. Venous stasis is happens when you have a reduced blood flow, dilated veins, decreased muscle mass, and or decreased muscle contractions, as it happens in immobility. Your muscles aren't squeezing those veins, or you can have faulty valves. There are examples there, a lot of different things. Immobility, I mentioned, sedentary job, prolonged sitting, all kinds of things. Varicose veins and venous insufficiency are a big deal here too. Prevention is the key on this one. Identifying the risk factors, teaching the patients and family. Those sedentary jobs, people need to get up and exercise, get up and walk around. Just even standing, we know now, is better than sitting. Also, post-op exercise during bed rest. Exercises, early ambulation, all important. Venous wall injury can be something as small as a venipuncture or cannulation for greater than 48 hours. Surgery, trauma, contrast dye, IV meds, all kinds of things. Diabetes is huge for venous wall injury, that small vessel damage. And then increased coagulability. Many different things cause an increase in coagulability, and they're all listed there. I'm not going to go through them. We talked a lot about that in the hematologic section. But one thing I also want to talk about that is a big deal here in prevention is smoking cessation. It's a very big key to prevention of thrombophlebitis. There's an increased incidence in DVT with advanced age. Could be a number of different factors here, problems with mobility so that they are sitting or not as active as they used to be. They drink less fluids, maybe because of access or because they're trying to prevent incontinence. Sometimes people become dehydrated because they drink less fluid, and then they have increased blood viscosity. So all of those things can increase the incidence. And so one thing you can do is encourage fluid intake and also provide a convenient means of toileting. If you need a bedside commode at night, if you have a male who needs a urinal, pretty easy things to do to help somebody with their mobility and decrease their risk for DVTs and for falls, I might add. I want to say a word here about superficial thrombophlebitis. It's something we don't talk about a lot, but it's something that nursing care is very important for because the key here is prevention. Um, some causes are IV therapy, of course, contaminated drug needles, which we don't have any control over. Um, Signs and symptoms, swelling, redness, warmth, very tender to touch. You can diagnose it with a venogram, an ultrasound, sometimes just patient history and exam will tell you all you need to know. And then to treatment, you want to discontinue the source of irritation, which would be, of course, DC the IV fluids and the IV immediately, and then modify whatever risk factors you can if IV drug abuse is an issue. Moist heat is helpful. Nonsteroidals, antibiotics, of course, if there's an infection present, maybe limit the activity of that particular extremity. But again, prevention is always the key here. Deep vein thrombosis is something that can happen as a result of thrombophlebitis. There is a care plan for this in your textbook that's pretty good. This is a picture of somebody's legs showing the difference between a leg with a DVT on the left and then a normal leg on the right. So what you'll see signs and symptoms is edema in one extremity, warm, red, painful area over where the thrombosis is. So to diagnose it, they'll do an ultrasound, they'll look at clotting times, draw a D-dimer, because remember that is clot byproducts from clot breakdown, and so that'll tell you if there's a clot there. A venogram can also get you a diagnosis. The treatment is compression, anticoagulation, and sometimes if you have recurrent DVTs, you'll get a vena cava filter, which is a thing that kind of looks like an umbrella actually that they put in your vena cava, but there have been some product manufacturing defects with those of late, so those aren't really given to people lightly. They really have to have a big problem before they'll put in one of those. But you know, that's not really your concern. Your concern is nursing management. So assessment, what to really look for, of course, is development of a pulmonary embolus. So you've got a stationary thrombus that, as I mentioned, is kind of floating along there in the bloodstream and then all of a sudden breaks off and becomes an embolus, which can cause pulmonary emboli or stroke. You are responsible for managing anticoagulation. You're responsible for pain control and also prevention of future clots. This is another picture of someone who has a DVT from your book. And what I want to point out here is when you're doing an edema assessment, if you have bilateral edema on your legs, think heart failure. If you have unilateral edema, think DVT. So here is a picture of some anti-embolism devices that I think you might be familiar with, and then also an IVC filter. So sequential compression devices are intermittent pneumatic compression stockings that they use postoperatively or when somebody's going to be immobile for a long time. Compression stockings are elastic hose. You might know them as TED hose. the lowest incidence of DVTs postoperatively is when both of these are used together. So they'll put TED hose on and then use the SCDs as well. An IVC filter, as I mentioned, sort of looks like a little upside down umbrella. They put it in the inferior vena cava, and the theory is it will filter out those clots. It's implanted by interventional radiologists or a vascular surgeon, and the sole purpose of its existence is to prevent pulmonary embolus. So this is just a summary slide that talks about thrombophlebitis, the signs and symptoms, diagnostic tests, therapy, which is what you're going to really be responsible for. And one thing I do want to point out is, they're going to give heparin initially for this, but you need to really be careful with heparin because heparin can cause thrombocytopenia. So really watch for bleeding in people that you are treating with heparin. Warm, moist heat, elevation, compression stockings, complications, of course, we mentioned of pulmonary embolus, but you can also have recurrent DVTs and chronic venous insufficiency, varicose veins. Sometimes it can be a one-off, sometimes it can be chronic. And then, of course, your nursing diagnoses are there. Pain, this is very painful. Can really make people nervous because they are afraid the clot is going to break off. And then risk for bleeding is big when you have somebody anticoagulated. And just also want to point out with the anticoagulation, heparin prevents further clots from forming. It does not dissolve the clot that already exists. You would have to use a fibrinolytic agent if you were going to dissolve the clot that exists, and they just don't do that with DVTs. They give heparin and Coumadin to keep more new clots from forming. Varicose veins are dilated, twisted, superficial vessels. They're very tortuous veins, distorted in shape by accumulation of pooled blood. Part of the reason that they are like this is because they have incompetent valves, and that allows the reflux of blood from the deep to the superficial veins. And that with the increased blood flow, then increases the pressure, and then that causes dilatation. It's usually in the saphenous veins. It can cause a lot of swelling of the foot and ankle because you have that increased venous pressure there, and remember the hydrostatic pressure forces fluid out of the capillaries, and it's also painful. There's just a lot of aching pain that goes on with it. You can have a familial disposition for this, uh, uh, disposition to lose vessel wall elasticity. Also, pregnancy can be a problem. Risk factor for this, obesity, trauma, recurrent DVTs, inflammation, and also long periods of standing. If you have a job or a reason that you need to stand a lot, like for instance, being a nurse. Treatment, elastic support hose, exercise your feet and legs during the day, avoid prolonged sitting, standing, anything like that. That gravity, keeping that blood down in those incompetent veins, is not a good thing. Weight reduction is always important here. Uh, any kind of exercise and walking that you can do to use your muscles in your legs to move that blood back up toward the heart is a good thing, and it will also help with weight reduction. Sclerotherapy is when they actually sclerose the veins so the blood can't pool there. They do that with a chemical vein stripping. They go in and kind of almost turn the veins inside out. And then there's also laser therapy that they can do. There are complementary and alternative treatments, some herbs, but really be careful with those because those can often have side effects and drug interactions. So chronic venous insufficiency is when you have valve damage and retrograde venous flow. So venous return is usually helped out by pumping action of your calves, and you have one-way flow directed by valves. But when those valves are compromised, you get bidirectional blood flow, and that's a problem. You get increased pressure in those vessels, and then edema comes from the increased pressure. The stasis of the blood flow causes blood pooling, and this may actually cause venous stasis ulcers. It also causes the leakage of red blood cells into the tissues, and when those break down, they release hemosiderin, which is where you get that brown color of the skin that's so characteristic in uh, chronic venous insufficiency. And then the fibrous tissue replaces the subcutaneous tissue with all of that hemosiderin in it, and it becomes very thick, hard, itchy, and scaly skin. So signs and symptoms, chronic edema, that thick brown skin I talked about, especially in the ankle area, stasis dermatitis, and venous stasis ulcers. Cellulitis is very common in chronic venous insufficiency. Treatment, support hose, elevation 8 hours a day if at all possible. Do not cross their legs. Avoid any kind of prolonged standing, tight clothes that is going to cause more pooling, and sleeping with their legs elevated to promote venous return is always a good idea. These are the characteristic skin changes that I was talking about with the chronic venous deficiency, the dark, almost brown, tea-colored skin, very, very thick in the lower part of the leg. Ulcers may develop in this tissue that does not have good venous flow, and it can extend deep into the tissue. So what happens is you get a real superficial wound and it just grows bigger and bigger. It is very difficult to heal because of the edema in the tissues. Uh, it may start out as a small, tender, inflamed area, painful, and your skin in this chronic venous insufficiency can break just with the slightest trauma. And so then once you've broken the skin, it just extends. I've seen these involving the entire lower leg. Treatment involves elevation, moist dressing, and compression. Sometimes you get vacuum assisted drainage because there is so much fluid in this skin. And sometimes you even need a skin graft because that's the only way you're going to get it to heal. Nursing management, of course, includes meticulous wound care, skin care for the skin that is not broken, constant monitoring of their skin, always checking it out and teaching them to check it out. Injury prevention, and then, of course, patient education on how to take care of their skin and care for their wounds themselves. I mentioned at the very beginning about there are differences between arterial and venous disease, and I want to circle back around to that at the end. I have a different presentation in arterial disease, but just want to do a little compare and contrast here. With venous disease, you have pulses because you have arterial flow. With arterial disease, you have diminished pulses. Skin looks very different in the venous disease. You've got that hemosiderin in the skin, and so you get the brown, thick discoloration. With arterial disease, you have poor perfusion, and so you get shiny, hairless skin with thick nails. There is almost always edema present with venous disease and not necessarily edema with arterial disease. Ulcerations are present in both cases, but they're very different kinds of ulcerations, different places on the skin, and different signs and symptoms of the ulcers, and very different treatments. You get necrosis and gangrene more from arterial disease. The pain in venous disease is the aching pain in the lower legs, whereas with arterial disease, you're talking about claudication with exercise. Nails, not such a big deal in the venous disease. In arterial disease, those very thick nails. And then hair, um, not a lot of hair that you see with venous disease because you have that thick skin, but with arterial disease, there is no hair. You just have hairless, shiny skin.